Today I'd like to talk about hepatitis B and immune suppression, or more specifically about reactivation of the virus with immune suppression. First, I wanted to go over the lingo associated with hepatitis B, because without that, you can't make sense of it. First is surface antigen. This is an antigen expressed on the liver cell that is infected with hepatitis B that you can detect in the blood. And it's the definition of having a hepatitis B infection, is that you can detect surface antigen. Surface antibody is the antibody you get when you have cleared the infection or if you have gotten a successful vaccination series. It can't tell the difference between those two, which is why we have core. If core is positive, it indicates that you have been infected with hepatitis B at some point. E antigen is something that we use a lot in hepatology. It helps us know how active the viral replication is. And if you're E antigen positive, you're having lots of virus replication. When that settles down and you start to control the infection, you develop E antibody. Of note, some of the therapies for hepatitis B are just aimed at going from E antigen to E antibody, not necessarily clearing the infection, because that's very difficult to do. We also have hepatitis B DNA. I tend to not get it a lot unless I'm monitoring therapy, as the level can oscillate and often doesn't help us make treatment decisions. So hepatitis B reactivation is defined as an increase in ALT, detection of surface antigen, and a rise or emergence of hepatitis B DNA. You can also have reverse seroconversion, where you go from surface antibody to surface antigen, and that doesn't necessarily have to have a rise in ALT, but it usually does. What are the risk factors for this to happen? They center around the virus, the host, and the immune suppressing factors. So the virus factors kind of make sense. The higher the viral DNA, the more likely it is to happen. If you're E antigen positive or actively replicating the virus, it's more common. It's more common in some genotypes, and also if there's co-infection with hepatitis C or hepatitis D. Chronic infection also makes it more likely than acute infection. The host factors relate to age. The older you are, the more likely this is to happen. If you're male or have cirrhosis, and you are much more likely if you have a disease that requires immune suppression. If you're thinking about immune suppressing someone, you should screen them. You can't just go by the demographics, or you're going to miss some patients. The risk of treating with immune suppression is more if your DNA is positive, if your E antigen is positive, if your surface antigen is positive, and if your core is positive. Rituximab is probably the worst for causing reactivation. Stem cell and bone marrow transplants, as well as chemotherapy for malignancies, also cause a lot of issues. But there is kind of a graded likelihood depending on immune suppression for things like anti-TNF agents for rheumatologic disease or IBD, Low-dose steroids, especially for short periods of time, are some of the lowest risk drugs. This is an algorithm which is very useful in thinking through this process. So the first thing you do is check the patient for surface antigen and surface antibody as well as core. If they're surface antigen positive, they're infected. And you need to figure out from the immune suppression if you should start prophylactic therapy now, or if it's such low dose that you can afford to just watch them. If they're surface antigen negative, but core positive, that means they had an infection in the past and there's still latent virus in their liver and they could reactivate. If they're receiving heavy immune suppression like rituximab or a bone marrow transplant or an organ transplant, you're probably going to want to start prophylaxis now. If they're core negative and surface antigen negative and surface antibody negative, they don't have evidence of past infection, but they're also not immune, so you should vaccinate them. If you decide to just watch someone, they need to be monitored every 1 to 3 months, and that monitoring needs to be continued for at least a couple of years after their immune suppression is over, because late reactivation can occur. So treatment versus watching depends on the drug regime and the virus status. You treat before you start if they're at very high risk, and remember that they can have a late activation. And Entecavir is usually the medication that we use because it has less chance of resistance than lamivudine, which we used to use. There are a number of papers available which change all the time, but they should be able to help you judge what to do when you find someone who's positive who needs immune suppression, but hopefully this will help you understand what the thought process is. Thank you.